I'm really excited to share some of the amazing clinical success that I've been able to have with Arterisil, and that's what I want to talk to you about. So, before we get into that, I thought it'd be helpful if I give you a little bit of background about me, and so you understand where I'm coming from a clinical perspective. So, I run the True Health Center for Functional Medicine. We do comprehensive primary care from a functional medicine perspective, and we also do consultative functional medicine. We have a number of chronic disease reversal programs for diabetes, for dementia, for cardiovascular disease, complex chronic illness. So we really do a wide variety of different things. But one of the things that we offer our primary care patients is an annual cardiovascular wellness assessment. So that includes an advanced lipid protein profile and NMR. We're going to look at vascular and systemic inflammatory markers, evaluation of endothelial health, and then an annual carotid CIMT evaluation so we can follow that over time as well. And then we take all of that information and generate a plan of action, an optimal wellness plan for their cardiovascular health every year. So I've had many years of experience doing that. I've been doing that for about 10 years. And in that time frame, I've had zero MIs. So it's a very successful program, the cardiovascular wellness program. And I have seen people have tremendous improvement, particularly in inflammation. But in some of the patients, we've had more stubborn plaque. And so I first learned about Arterisil at a conference last year, and I was very excited to hear about kind of this new frontier in cardiovascular wellness, looking at the endothelial glycocalyx. It wasn't something that I had dabbled in before, so the data was really interesting and very compelling. And I was excited to think about how I might be able to start applying that in some of these tougher cases where I had maybe had some improvement in plaque, or maybe we had kept their plaque and their arterial age stable, which I think we all know that the natural progression of this disease is for it to continue to progress, to have the intimal medial thickness increase as we age, our so-called vascular aging, and then to have plaque gradually continue to accumulate, particularly if we don't do any type of intervention. But even when we're using conventional treatments like statins, or a lot of the things that we all do where we're working on their root causes, their inputs of inflammation, their nutrition, their sleep, their stress management, all of those things that we all do, sometimes the best we can get is just stability. And while that's still an accomplishment, and I'm happy when I can do that, I really wanted to get more, and I really like to see regression. And so that was where I thought Arterisol might have a role in some of my patients. So I had talked to Ed Hoyt and Chen Chen, the CEO and Chief Science Officer for Calroy Health Sciences, when I was at the conference, and we were talking about considering some clinical research, and I was looking forward to doing that. But that takes a little while to get going. And when I got home, I was pretty hot to trot to try this out on some people, and I wanted to see what I could accomplish. So, as I was seeing those cardiovascular wellness patients, I started recommending Arterisil to some of my tougher cases. And that's when I really started to see what this could accomplish. So, my first case experience was this patient. She's now 71. She has eccentric plaque in her coronary arteries, hypertension, hyperlipidemia. So, we started doing advanced assessments on her back in 2007. Her first CAC was 117. So, at the time, that put her in the 75th percentile for her age. Then her next one that we did in 2013 at 340 put her well above the 90th percentile. And that's really when we started doing a lot more intervention, because I had progressed at that point in my integrative knowledge as well. So we were throwing everything at her, that resveratrol and green tea extract and alpha lipoic acid and plant polyphenols, and you name it, we tried it. So by 2015, she still had a CAC of about 508. again at or above the 90th percentile for her age. And not long after that, she had an ER visit and a hospital admission for classic angina. And that, of course, prompted a cardiac cath, but the cath was completely clean. She had widely patent arteries. So her plaque was all of that plaque that we were seeing on her CAC was all eccentric plaque. And because she had the angina admission and had a cath, of course, she was put on Crestor by the cardiologist and has been on that since. So we'd been watching her serial CIMT scan since about 2015 on the Crestor, and she still had progressive carotid plaque accumulation. So I saw her about 3 months for a routine visit, about 3 months before her next annual wellness evaluation, which was going to include her next carotid scan. And so I put her on arterial because I wanted to see what could we accomplish in 3 months because we had the scan coming up. Well, the results blew me away. So on the left hand side over here, you can see this is her scan that was done in 2018. And so she had plaque on both in both carotids, and her arterial age was about 64 at her chronologic age of 70. So you could tell we'd been doing some work. And then over here, just 3 months of arterisol, we were able to accomplish this huge change in her plaque. Four of the five plaque areas had regressed to the point that they were no longer greater than a millimeter, which is the clinical definition for plaque. And we only had one residual area that still met the criteria. So that was a really impressive result. The next couple that came in weren't necessarily my tougher cases, but they were interesting nonetheless. So this is a 52-year-old female. She's an athlete and has some significant genetic risk for cardiovascular disease. Her carotid scan was kind of surprising because great lifestyle, excellent lifestyle choices, and yet she still had plaque in that left carotid. So she took arterisol for 6 months, and we were able to see the resolution of one of those two plaques on her scan. And in that same time period, we also saw a reduction in her arterial age by about 3 years, too. The next one was this gentleman. He has a significant genetic risk as well. His lifestyle history is interesting because he's never smoked, never had any alcohol consumption. And you can see he's a bit of a biohacker and always game to try something. So he already had a good vascular age at 43 at his chrono age of 46. Nonetheless, on 6 months of arterisol, he was able to march that down all the way down to 37. So he had a 10-year improvement overall from his chronological age. So these are all just very interesting results. So just to have some perspective, what can we really see in terms of how do the statins perform? So there's quite a few studies. These are the ones that I wanted to highlight. We had 33 patients on rosuvastatin, and they were able to show a 25% reduction in what's called the lipid-rich necrotic core. That's doing the MRI plaque view, which is predominantly a research MRI method of evaluating that lipid-rich necrotic core. Another study, interestingly, same number of patients, they were treated with atorvastatin for 3 years. They had an average 38% reduction in that lipid-rich necrotic core. And other published studies, quite a few of them, have shown significantly less reduction, anywhere from a little over 1% to just under 7.5%. So that just gives us some perspective on what statins can accomplish. Interestingly, no stenosis reduction was observed in any of those studies. So that brings us to our retrospective study that we started. So I had a number of those tough cases that I had started on arterisol after attending the conference. And so we decided to go to look back at what did we accomplish in that time frame. So when I looked at the people that I had recommended arterisol to, their usage was all over the map. We had anywhere from 4 months to 11 months of usage over about a 9 to 12 month period of time. I thought, this is terrible data. I don't know what we're going to do with this. But then I realized that it really was a pretty good sense of clinical real life. We recommend these treatments to our patients, but they don't always do exactly what we say. And so it gave us a real life perspective. So that in a way made the data even more interesting to me. So I want to talk about or highlight a few of the tougher nuts. The first one is a 50-year-old male. He's a world-class jiu-jitsu competitor, so very fit, very athletic. Diagnosed him with hyperlipidemia back in about 2011. Really strong family history of CVD. Dad died from CHF at 53 from hypertensive CHF. He also had a history of hyperlipidemia with a very high LP little a. That unfortunately was inherited by my patient who, in the years I've been taking care of him, I think peaked out at an LP little a of 182, which is massive. So that goes along with this increased stroke family history. Both grandparents on each side died of strokes. When we did his first CAC back in 2016, he had a score of 6. That put him in the 70th percentile for his age group, but all of that plaque was in his LAD, so really dangerous. We had serial CIMTs for him, looking at total plaque. So thinking back to the previous diagrams, we add up the plaque on both the right and the left sides. That gives us a total plaque score. His, with all of our efforts, had gone over that 3-year period from about 11 to about 8.9. So I was able to accomplish about a 19% reduction. But on arterisol, his total plaque reduction was another 57% in just 1 year. So that was really amazing. Then my next patient is a 70-year-old with hypertension and hyperlipidemia that was diagnosed way back in the 80s. He also had pre-diabetes bumping right up against the diagnostic zone for diabetes because he had an A1C of 6.4. We all know that that's really the same metabolic problem. He ended up getting a fib in 2015, and then this past year had angina and was diagnosed with CAD and had an LAD angioplasty and stent placed in February of 2019. So he was my one unplanned revascularization, and he did not have an MI, did not have any cardiomyocyte damage. So we caught it at the right time, and that was a good thing for sure. His dad died of CAD. His brother had a sudden cardiac death. So just a lot of history going on for him. His serial plaque scores went from, hang on, my thumbnails are in my view here. So from 10.4 in 2016, still about the same, 10.4 or so by 2019 with all of our effort and reversing his diabetes with an intensive lifestyle program. 1 year of arterisol for him, and we accomplished a 76% total plaque reduction. Really amazing. So the last case that I wanted to highlight is this gentleman, 62-year-old male executive with hyperlipidemia. He actually had a 40-year history of ulcerative colitis. And about 6 years or so ago, I diagnosed him also with celiac disease. So a lifetime of inflammation. And we all know that those are huge risk factors for CVD. His mom died at age 72 from a sudden cardiac death. His CAC of 4 in 2015 put him in the 30th percentile, so not bad at the time, but again, all in the LAD. His serial CIMTs stayed about the same. We got about a 22% reduction over that 3-year period or 2 or 3 year period that we were looking at on that one, and a year on arterisol with him. And again, knocking it out of the park with a total plaque reduction of another 64.5%. So that brings us to our retrospective study preliminary data. where all three of those patients are highlighted here. And our overall group, when we're looking at the maximal plaque, so any one single plaque that was the greatest plaque size is what we were looking at and how that changed. So in the example over here, this would be 2.072 would be the maximal plaque on this particular patient. And then we compared that in our before and after. And so you can see we got about a 26.5% reduction on maximal plaque, thinking of that in terms of the occlusion, in terms of reduction of occlusion and stenosis, because we looked at the statins where we didn't see any reduction of stenosis. Then the maximal plaque on the left-hand side, similar results coming in around 22. And then where we really saw the big change was on this total plaque data. So really amazing data. Our average on our visit one, so our before CIMT was 5.3, was the average total plaque on our participants there. And the average after arterosil in visit two was 2.9. That was a 52% reduction. And it's interesting because if you look up here in the data, I asterisked the 3 patients that we highlighted as we were going through, and there's a couple people that had actually an increase in plaque. And interestingly, both of those patients had had either a significant mold exposure during the year or had had mold treatment initiated during that year. So I just thought that was an interesting finding. It was also interesting that all of the plaque had been modified from calcified and heterogeneous to only heterogeneous. So we were really seeing some difference in the remodeling of the plaque as well. So that brings us to our prospective study that's now underway. We're going to do another set of data on our initial patient group, the first group that we just looked at for the retrospective. And then now the prospective study will be 10 subjects from the community that we're going to treat more deliberately with 6 months, appropriate dosing twice a day continuously. And then we're going to see their before and after. And I can't wait to see what we find on that. So Arterosil is readily available to us on all of these distribution partners. Your patients can also order it directly on arterosil.com. You need to have a provider code for them, so you just need to apply for that. And they have some really great both patient and clinician educational material. There's a summary of the research data that's available there, and you can see the ongoing studies as those start to come in. I know Ed Hoyt, the CEO, and Chen Chen, the Chief Science Officer, are going to join us for the Q&A. So in case there's anything that's beyond me, we can have them address those as well. So I talked a little bit about whether or not what the typical dosing is for Arterosil, and that's twice a day. We've been asked before if it's been studied at any higher dosing and whether or not that can have any additional impact. And it has been looked at as high as 6 capsules a day, so 3 twice a day. And there is a shorter time period to see some of the improvements that we've seen in the studies. I don't know, Ed or Chen, do either of you want to add anything about higher dosing schedules?
Thank you, Dr. Berg. As you've said, we've used a higher dose. Double the dose is relatively common. As far as experiment goes, we've used even triple or quadruple doses, and they seem to be quite safe, although we do not normally recommend that. But we experimented with that, and it works quite well. There is a cumulative effect as far as regenerating the endothelial glycocalyx with arterosil. So higher dose for a short period of time seems to help. Again, those are the experiments we did in the past.
Mm-hmm. Yeah. The other thing I know that we've been asked quite a bit in the past is about the PlaqueView MRI as opposed to CIMT. And I know that PlaqueView MRI is something that's really only available in the research setting right now. And there's been some work on trying to have that become clinically available. But for now, the CIMT, which is readily available and very inexpensive, is a great surrogate because you can see that we get approximately equivalent results with the CIMT scans as we see when we're looking at the plaque view MRI. Let's see. I have
Christine, I
all,
had,
yeah.
this is Ed Hoyt. I had somebody just text me a question that was related to, is it contraindicated for any blood pressure meds or blood thinners, et cetera? And there are no known contraindications for arterisol. We've used it in thousands of patients that are on those types of medications.
Mm-hmm. And I think pretty much all of the patients that I have used it in as well have all had, as I listed, several comorbid conditions that they've been receiving treatment for too. I know that there have been reports of some GI side effects in some people. I actually have not had any adverse effects reported to me in my clinical usage. So, but I think that that's the only side effect that we've had explained to us. And the active ingredient is a fiber. And so some people can have some GI distress with fiber usage. But do you want to talk any more to that? Is there anything I'm missing in that arena?
Um, I think you covered it correctly. We have some very few cases reporting on GI discomfort. As you pointed out, this is a fiber-like prebiotic. It has that kind of effect, so it is conceivable there might be some interaction over there, with certain patients. But so that's about all we have received as far as the adverse reports.
Yeah.
Mm-hmm.
And we don't know the total number of patients because we sell through licensed healthcare practitioners only, but we estimate that there's probably close to 20,000 patients that are taking arterisol. We have 3 of those reports of stomach upset. So it's definitely not anything that's widespread.
No, not at all. Like I said, I haven't had a single reported any adverse effect at all. There was a question that we had in the past too. I'm looking at that because the glycocalyx helps with nitric oxide production by increasing the health of the glycocalyx layer, are we also then increasing nitric oxide production? And the answer to that, I think, is a resounding yes, that by improving the health of the glycocalyx, we improve endothelial function. And that, of course, is extraordinarily important in the health of the artery wall. I like to describe it to patients when I'm describing to them what this thing that they've never heard of is going to do for them. I tell them if they can imagine all the nonstick pans that I've asked them to throw out, and where those nonstick pans have had the non-stickiness worn off, and then everything you cook sticks to that spot, that's kind of like what damage to the endothelial glycocalyx does in the artery wall. So it creates this kind of sticky patch or this damaged patch where we're going to have those adhesion molecules attach, where we have less protection for the migration across the endothelium. And that's part of the way that it promotes, it doesn't promote, but we lose the protective barrier to the plaque production. And so that's how I like to explain it to patients. I don't know if you've heard any other good analogies, but that one seems to work. People can definitely understand that one.
Yeah, I use that one also. And I like how you positioned it of all those nonstick pans that you've instructed them to throw out. I'm going to add that into mine when I say that.
Exactly. Oh my goodness. Yeah, just moved a friend who had an armamentarium of all Teflon coated pans, and I just shook my head. Oh my goodness. So let's see. One question that I thought was really interesting that maybe we can address too is how effective is arterisol in helping address problems associated with familial hypercholesterolemia, because some of the mechanisms are a little bit different in that. And I know that we all have talked about that the role of arterisol is not actually a lipid lowering therapy, that it's this protective coating that we're repairing inside the artery wall. But in individual cases with FH, I would imagine that there is significant improvement from the damage that they have from having those extremely high cholesterol numbers, and usually very high, small, dense LDL. Do we have any more information on that for FH patients?
We have some information in general related to the cholesterol. In some patients, we do have reports back. There's significant reduction of cholesterol, although the mechanism is not very clear. We are studying it. There might be some interaction in the liver with some enzymes related to that, but we do not know for sure on that one. Because endothelial glycol calyx prevent lipids, including LDL and the cholesterol, penetrate or damage the endothelial wall. So it will help patients with AH, and especially over time, the high blood lipid would cause damage of the wall. So that seems to be the mechanism that the products that help those patients.
Mm-hmm.
Thank you, Dr. Chen, and thank you, Christine, for presenting. I very, very much appreciate it. We're kind of wrapping up here. We're at the top of our time. And so very exciting to see what you're doing for your patients. And I hadn't seen some of that data you just shared in terms of like how long it took for some of those people to move the needle so little, and then the big result that you got in a short period of time. I now can see why you're so excited for your patient base. So thank you.